Good afternoon, and welcome to the workshop, New Cancers After Transplant or CAR T-Cell Therapy, Who's at Risk? My name is Steve Beekler, and I will be your moderator for this workshop. It's my pleasure to introduce today's speaker, Dr. Marcelo Pasquini. Dr. Pasquini is a professor of medicine in hematology and oncology and a member of the Blood and Marrow Transplant Group at the Medical College of Wisconsin in Milwaukee. His clinical work focuses on transplantation and cellular therapies, such as CAR T-cell therapy, to treat different diseases such as multiple myeloma, acute leukemia, myelofibrosis, and myelodysplastic syndrome. Please join me in welcoming Dr. Pasquini.
Hello. Thank you very much, Steve. And it's a pleasure to be here to participate in this symposium. I will, in the next 30 minutes, talk a little bit about the complications post-transplant CAR T-cell, mostly related with the development of new cancers. So here are my disclosures. This is all related to my work related to CAR T-cell and the outcomes of CAR T-cell with the transplant registry. So the topics today, I will cover the development of new cancers, the definitions, considerations, and a few examples to illustrate what we mean about this and what is the main risk related to this complication. What we need to know about in terms of the components or risk factors for developing these malignancies after a bone marrow transplant or CAR T-cell therapy. And in terms of a CAR T-cell, this is a new topic, and even though it's similar to a transplant, there are some peculiarities that I would like to cover, like, for example, why, when, and how, and most important, who's at risk. So what are new cancers? What is not a new cancer is a relapse or recurrence of the original cancer diagnosis. So it's the development of a new malignancy that is not directly related to the malignancy that was used or there was the transplant was used to treat. There are a few terms you see in the literature about this. One of them is subsequent primary neoplasms, which is really a favorite term, especially from survivorship studies. The other term is subsequent primary malignancy. They're all divided into SPN or SPM for short definitions. We try to avoid using the term secondary cancer because that implies that they was secondary to the treatment, and sometimes you don't know the relationship or causality of these events. Another term that is used frequently is therapy-related malignancy. In terms here, therapy-related acute myeloid leukemia or therapy-related myelodysplastic syndrome. Subsequent cancers may happen in any cancer therapy and in their absence of cancer therapy. So patients, for example, having a skin cancer may develop other cancers in the future in the absence of a specific treatment aside from surgical treatment for that skin cancer. After CAR T-cells, one important message is that even though there's a risk, the benefit of the treatment outweighs the risk of this complication. And I'll go over this in a little bit more details now. So starting with a few examples to illustrate the definition of these second malignancies or second cancers. There are diseases that are in the same spectrum. For example, development of ductal carcinoma in situ of the breast and transforming that into an invasive breast cancer. Some of these events are pre-cancers, for example, MGUS or monoclonal gammopathy of a certain significance, which is the detectable protein in the blood that can eventually increase the risk for development of symptomatic multiple myeloma. Similarly, MDS or myelodysplastic syndrome was also considered a pre-leukemic state in the past because patients have a higher risk to develop acute myeloid leukemia after this diagnosis was made. Another example are patients who develop chronic lymphocytic leukemia, which can be transformed into large cell lymphoma. So all of these examples are diseases that are cancers that are in the same trajectory of development of the primary one that was initially detected. Another example are complex relationships. So this, for example, a patient who developed multiple myeloma, who received an autologous transplant, and then developed myelodysplastic syndrome after the autologous transplant, then developed an allogeneic transplant, then was treated with an allogeneic transplant for the MDS, developed graft-versus-host disease, and then developed a basal cell skin cancer. So in this example, there are three distinct different cancers in that patient's trajectory for their treatments. The other example is patients receiving breast cancer treatment with chemotherapy and radiation and developing myelodysplastic syndrome as a result of exposure to these therapies. And subsequently, this MDS progressed into acute leukemia in a similar example as the blue box above that says the disease in the same spectrum. And then the patients develop allogeneic transplant, and then developing another illness called post-transplant lymphoproliferative disorder associated with Epstein-Barr virus infection. So these are complex situations that can occur in the real life, in real setting, and so and some of those are examples of second malignancies. Another type of trajectory which has unclear relationship is, for example, a patient who has developed a skin cancer called malignant melanoma, then develop another cancer, a multiple myeloma that is unrelated to the melanoma, and underwent an autologous transplant for the multiple myeloma and started with lenalidomide maintenance as part of their therapy, and eventually the melanoma returned. So it's unclear whether the multiple myeloma is related to the melanoma or whether the multiple myeloma or the treatment of this disease increased the chance for the development of the relapse of melanoma later. As you can see, there are complex relationships, and sometimes it's not clear association between whether the treatment or the cancer per se may increase the risk for a subsequent malignancy. Another important element is to understand that the likelihood to develop a cancer diagnosis increases with age. As our organs age, there is increased chance to accumulate errors that may result in the development of a malignancy. As you can see here in the SEER database, which is a U.S.-wide epidemiologic assessment, you can see over by different genders, female and male in the blue and green, and by over different 5 years of increments of age and increased risk of any cancers. If you look at this specifically for myelodysplastic syndrome, there is a very steep increase after the age of 60 for the development of myelodysplastic syndrome. We know now that there is development of different predisposing factors, which is development of different clones in the bone marrow that can eventually develop an MDS that also increases with age. That tells you a story of as the bone marrow organ ages, errors may accumulate over time, increasing the chance for these diagnoses. So what are the associations and how these cancers may develop in the setting of transplant? So here there's a study that was done back in 1998, which is still relevant today, that really describes the association of multiple factors. As you can see here, there are infection, the chemotherapy, predisposition genetically. And if we go one by one, we can define this a little bit more. So the cytotoxic therapy, what is important? Is all the cytotoxic therapy that the patient was exposed to during the course of their treatments. So that has a cumulative effect. So for the treatment of acute myeloid leukemia or acute lymphoblastic leukemia or other cancers. But mainly is the utilization of the conditioning regimen, which depends on the intensity, being high intensity or lower intensity. The intensity defines that risk of subsequent malignancies. Also, the utilization of total body radiation as part of the conditioning regimen is an important risk factors for development of second cancers. subsequent infections. For example, as I mentioned earlier, the infection with a virus that's called Epstein-Barr virus that commonly causes mononucleosis or mono in young adults may still be present in the system in a patient going to a transplant. Whenever there is immunosuppression happening after the transplant, there is a expansion of these viruses that may cause what we called a type of lymphoma that we call lymphoproliferative disorder, and it's called post-transplant lymphoproliferative disorder, or PTLD for short. Depending on the level of immunosuppression of the bone marrow transplant, this has an increased risk, especially for transplants that are using T-cell depletion as a form of GVHD prophylaxis. Immunosuppressive therapy as well, as I mentioned, the type of GVHD prevention and the conditioning regimen, the utilization of ATG or anti-thymocyte and again T-cell depletion may increase the risk of these infections and also subsequently increase of development of these malignancies. The immunodeficiency after transplant, which is a combination of factors as mentioned. The development of GVHD or antigen stimulation, severity of it, the type, intensity of chemotherapy because of organ damage increases the risk of GVHD. The GVHD decreases the ability for the immune system or the new immune system to do a proper immune surveillance of new malignancies that occur. It's not uncommon that patients with severe chronic graft-versus-host disease may develop skin cancers as a result of that as well. Again, regarding genetic predisposition, there are syndromes and other diseases that have increased risk for malignancy despite the use of transplantation. One of those examples is Fanconi anemia. But also, as patients increasing age, as I mentioned earlier, there is an increased risk of other malignancies by the process of aging of each organ, as mentioned before. So in the course of the transplantation, as you look here in this graph, in the beginning, the day 0, 1 year, and 10 years, so it's over time, the risk of a disease relapse is really high in the beginning, and it decreases over time among survivors of cancer, survivors of the bone marrow transplant. Then early on, you have a risk of this PTLD, which is that infection related, which is the period of time with highest degree of immune suppression. Also MDS or AML as a result for exposure from cytotoxic therapy or therapies in the patient's life. And then ongoing risk of second solid cancers over time, increasing it. The period and the timeline, as mentioned earlier, differs by different diseases. As you can see that some cancers would occur over 7 or 8 years, and others will occur earlier, for example, MDS and acute myeloid leukemia. This is a study in children, and I would like to point out the risk for Fanconi anemia. And Fanconi anemia is a disorder, a genetic disorder that interferes with the repair, the genetic repair that happens in our cells. When there is these mutations, patients have a higher risk to develop cancers like head and neck cancers, and they're very susceptible for cytotoxicity or cytotoxic therapy-related cancers. As you can see here, Fanconi anemia row is highlighted in blue. You have a second cancer malignancy risk of 5.4%, and there is almost a 50 times higher risk of cancer compared to the normal population with the same age. Looking at multiple myeloma specifically, there were several studies that were done to try to understand a little bit more, and this explains, similar to the other graph, what other factors that are related to the association with second malignancies. In multiple myeloma, there is a use of cytotoxic therapy as treatment, especially in the autotransplanting. But also there is other drugs, for example, lenalidomide, that may interfere with the development of malignancies as well. So the magnitude of the risk can be shown in this graph as the number of risks increased as these curves are shown here over time. This time is 5, 10, 15 years, and so forth. And you can see here that the development of cancer in red is about less than 10% over time in this study, and which is lower than the other risks, which is the development of the cancer or development of the recurrence and death related to the multiple myeloma per se. This is relatively old. We have a study that was done using the registry, also looking at this and separating this curve over time. This again goes up to 15 years, looking at different events. In green, for example, the development of any other secondary cancers, which is about 10%. The development of AML and MDS, less than 5%. The risk of mortality related to disease, and the relapse occur in purple. So that gives you a visual about the magnitude of the events that are expected and the timeline that they may happen. A study that was done in multiple myeloma to understand the role of maintenance using a drug called lenalidomide over time was done by the U.S. corporate groups. Patients were randomized or divided into two groups, one receiving placebo and the one receiving the lenalidomide continuous therapy. And there was increased risk for patients who received lenalidomide in terms of malignancy, as you can see here on the left side. But the overall benefit was actually better to receive lenalidomide, as is still with the risk of second malignancy. Patients experience better survival. But still, that calls the attention that addition of lenalidomide after an autotransplant increases the risk of second malignancy, really informing the practices of surveillance and education of the patients. Now, this looking at the proportion of transplants and cell therapy done in the United States. As you can see here in blue, you have the number of autologous transplants done a year over time, the number of allogeneic transplants, and also in blue you can see a light blue the number of CAR T cells. That tells you that the proportion of patients who are receiving transplants are increasing. Not only that, there is an increased survival, and it's estimated there will be a large number of transplant survivors given the improvement of survival after transplant. So the issues of second malignancies or second cancers are very important in terms of surveillance and patient education. As you can see here on the left are allogeneic transplants, on the right autologous transplant, and this is an overall survival curve. And each of those lines represent a period of time. As you can see, the higher the line is the less the mortality. So the more recent years, even for allogeneic transplants, this overall survival of patients are much better than they were 2 decades ago, showing this improvement of the probability of being a long-term survivor with an allogeneic transplant or an autologous transplant. So what is the impact right now of the second malignancies that happen after a transplant? Here are 2 pie charts demonstrated by age less than 18 and greater than 18 of the most common causes of death that may occur after an after an allogeneic transplant. You can see in blue the most common causes, unfortunately, are the disease that was treated for the transplant coming back and being the main cause. The magnitude of the risk for patients who develop a malignancy, a second malignancy after transplant is 1% for younger than 18 and 2% and over 18 years old. So in summary, second cancers can occur after transplant, although the magnitude is low. Cancer education and prevention is part of all survivorship guidelines for patient care. So the factors that reduce the risk is improving understanding of this risk, providing and doing frequent cancer screening procedures, including colonoscopy, mammograms, skin exams, prostate-specific antigen blood tests, oral health assessment, pap smears, and other methods for preventive health. Following guidelines for wellness practice with diet, decreasing tobacco use, and so forth. And of course, decreasing the risk of exposures, including UV light, as there is an increased risk for skin cancers. So that is a summary of the second cancers after transplant. Now we'll shift to CAR T cells. CAR T cells are genetically manipulated cells that are done mostly ex vivo and infused to the patient to fight the cancer. As any genetically modified product for any intent, there is a standing guidelines from the health authorities, the FDA and the EMA and others around the world, that patients receiving these products are required to be followed for 15 years to understand the risk for other complications. The most important one is the developing of other cancers coming from the genetic manipulation of the cell before infusing in the patient. The genetic manipulation is often random, and it can disrupt important genes and lead those cells to turn into a cancer. So there are several CAR T cells that are approved in the United States. They are listed in blue here. The first one was approved in 2017, and then you have additional ones that came up. Additionally, what happened after the approval of these, there were expansion of the labels, which are listed in green in the bottom of the timeline, demonstrating increased utilization of the CAR T cells in earlier phases of the disease, or in other similar diseases that express the same target as the initial ones tested. The idea was, in the CIBMTR, since we collect information on CAR T cells, how we would respond to the requirements for long-term follow-up of these patients who receive CAR T cells. We worked with each of the manufacturers of CAR T cell and developed a project to follow these patients long-term. So we're developing black here different projects that are observational prospective studies, meaning we don't dictate the care of the patient, but collect information on what happens to them whenever they are seen at their local physician. We'll collect information as, and patients will need to sign an informed consent to share information with the CIBMTR, and then we collect information related to the product, the disease, and the outcomes that happens with the patient after, with the main focus to understand the magnitude of the risk of second malignancies and understand whether the addition of the CAR T cell may lead to a specific type of cancer that may is specific to the CAR T cell. I showed this before, but here demonstrates the increased use of CAR T cells over time. There's a total of 23,000 patients, most of them receiving a standard of care. In November of 2023, the FDA launched a communication with concerns that the utilization of standard of care CAR T cells, either directed for treatment of myeloma or treatment of lymphoma and acute lymphoblastic leukemia, had a potential to increase risk of a specific type of cancer related to T cells. As you know, T cells are the cells that are manipulated for CAR T cell, and that really caused a lot of concerns about what is the magnitude of the risk. A group of investigators came together to prepare a response to the FDA communication to try to understand the magnitude of the risk some more. As I mentioned earlier in this presentation, there are risks inherited for any cancer therapy, and the question is whether the risks of it, the risks are outweighed by the benefits of this therapy. So when we looked at the CIBMTR, we looked at total of a number of patients who who underwent CAR T cell therapy for different indications as seen in this table. And we looked at that. We saw that among patients who would develop second malignancies, there were a total of 6.4% out of patients who had non-Hodgkin's lymphoma and 6.4% patients who developed multiple myeloma. And what was interesting among patients with ALL, although there was 1.6%, there was a proportion of patients who had a second AML after it that was reported as second malignancy. With further analysis, what we uncover is that some patients, depending on the type of acute lymphoblastic leukemia, after exposure to the CAR T cell, may relapse with a different type of leukemia called AML. So this is called lineage switch and not necessarily related to cancer. So if you remove these 7 cases, the risk of subsequent malignancy in children after CAR T cell ends up being less than 1%. So you can see the variability between 6.4% and less than 1%, depending on the indication, which is important because there is a very big difference in age with patients with non-Hodgkin's lymphoma and myeloma having a median age of over 65 years old, as in ALL, these are mostly pediatric patients. You look at the distribution again, the most common malignancies representative in the CIBMTR were skin malignancies and myelodysplastic syndrome. We identified only a handful of cases that will be considered T-cell malignancies, but we could not, based on the information shared with us, have a causality between the CAR T-cell manufacturing and the development of these called T-cell malignancies. All of those, even though they're different names, they're all different kinds of T-cell lymphoma types. A large study was done in France by the French registry, looking at the risk for development of T-cell malignancies or cancers that are derived from T cells that could be related to it. In a total of 3,000 patients, they were not observed cases of these T-cell malignancies, telling you that this is a really rare event that may happen. Although there are cases in the literature, for example, this noted above, that a patient who received a CAR T-cell for multiple myeloma developed a T-cell malignancy involving the gastrointestinal tract. And those T-cells have the CAR T-cell in there, suggesting that could be an association with this. These are still very rare, related to the number of these CAR T cells being done, but still is an item under study. So if we translate the information that we learn from the transplant to the CAR T cells, we can say the impact of the cytotoxic therapy is similar, but now these patients receive what we call the lymphodepleting therapy, and also bridging therapy and any other therapy prior can increase the risk of second malignancies. Infection, similar, can happen because these patients become really immune suppressive and can develop these malignancies as well, similar to the transplant. The CAR T cell type is important because manufacturing is different for each CAR T cell. It has a different construct that is included and a different mechanism for developing them. And also, additional treatment after CAR T cells may increase the chance for subsequent malignancies as well. There is an ongoing immune dysregulation after CAR T cells because the part of the immune system responsible for production of antibodies is extremely inhibited after the CAR T cell therapy. CAR T cell complications do increase inflammation, which may have an effect on development of myelodysplastic syndrome. And again, increasing age or prior cancers may also do the same effect. So second cancers after CAR T cell is summary. The risk of second cancers after CAR T cell therapy is present and differs by disease indication. As I mentioned to you, lymphoma and myeloma being close around 6 and acute leukemia less than 1%, but that could be a fact of patient's age and the therapy that they received prior to the CAR T cell. The most common cancers are skin cancers and MDS. MDS appears to occur a little earlier than what is observed in transplant, which is a point of study at the moment. And what can be done to reduce the risk? I think the same points are relevant here with active cancer screening, similar to what is recommended to transplants, and annual visits for 15 years to understand if there is other points that could lead to development of second malignancies. In conclusion, second cancers are an unfortunate complication of CAR T cells and transplants, and they can occur. The risk is low, and the benefit from these therapies outweigh this risk. The magnitude increases with age and other factors as mentioned earlier, and understanding who is at risk increases our ability to monitor and treat them earlier. Reducing the risk is an ongoing goal to mitigate some of the inflammatory complications of the CAR T cell, for example, and limiting some of the intensity of the regimens used for transplant and reducing the risk of graft-versus-host disease. I would like to thank your attention, and I'll be happy to take questions.
Thank you, Dr. Pasquini, for this excellent presentation. We'll now begin the question and answer session. If you have a question for Dr. Pasquini, please type your question into the chat box on the left side of the screen. We'll answer as many questions as possible. Our first question is, after auto-transplant, would CAR T possibly be used to treat a secondary cancer?
Yes, the utilization of the indications of CAR T cell does not change. And it depends on what malignancy comes up after the transplant. If what happens after the transplant is the development of acute lymphoblastic leukemia, a CAR T cell can be used for that treatment. So it's possible. CAR T cells at the moment are limited by the types of targets that the cancer expresses in their surface. So at the moment, there are two types of targets that CAR T cells are used against. One is called CD19, which is expressed in lymphoma and acute lymphoblastic leukemia, and BCMA, or B-cell maturating antigen, which is commonly expressed in patients in cells of multiple myeloma.
Thank you very much. This person wants to know, what is a common disease trajectory post-CAR T when diagnosis was DLBC lymphoma in the CNS?
Can you repeat the question?
Sure. What is a common disease trajectory post-CAR T therapy when the diagnosis was DLBC lymphoma in the CNS?
Yes.
Central nervous system.
Yes. So right now there is a limitation on using CAR T cells for this indication. Looking at the registry, there is an increased interest for patients who have CNS lymphoma, central nervous system lymphoma, which means involvement of the cancer in the brain and the fluid that surrounds the brain. So that can happen in two different instances. Either there's primary CNS lymphoma, which means the cancer is only in the central nervous system and nowhere else, or the cancer originated in a tissue and also expressed in the brain. So in the latter, you have more cases in the registry that we see. In essence, the trajectory after the treatment for these conditions are slightly different than for patients without involvement of CNS. Patients with CNS do respond to CAR T cell for therapy, but the response rate is not as high as the patients who do not have CNS lymphoma. So the indication is still to proceed with that, with CAR T cells, because there is circulation of CAR T cells in the central nervous system, which allows that to have an activity in the tumor as well. I hope I answered the question.
Thank you for that. Here's an either-or question. Are secondary cancers caused by the chemo infused during transplant, or because the body reacts to getting its stem cells back?
That's a good question. So the chemotherapy, mostly stating chemotherapy as the classical chemotherapies that affect the cell division, they are toxic to the DNA. So the cells and organs that are most sensitive to the effects of the chemo are organs and tissues that are constantly undergoing cell division. So, for example, your bone marrow is an example. You're constantly producing blood. Thus, whenever the chemotherapy presents, that can cause some changes into the DNA that these cells have in the bone marrow, and that increases the risk of developing myelodysplastic syndrome, as an example. So the effect is not necessarily related to the stem cell, but related to the chemotherapy that is utilized. There is historically, depending on the type of chemotherapy, that's what we call latency or expected time that the cancer may occur. So some types of chemotherapy may take about 5 years, and others about 7 years. That's well described in literature. What is arising right now is whether the chronic inflammation that happens with complications after transplant or complications of CAR T cell may play a role in pushing an increased risk for second malignancies that may occur with that overstimulation of the bone marrow. So to answer this question, in summary, the association is mostly related with the chemotherapy.
Thank you. This person wants to know, can you elaborate on the Oticell CAR T treatment? Can I receive this treatment if I already received a BECMA which has run its course? Are there any treatments that would prevent the use of Oticell?
So that's a question related to use of CAR T cells after CAR T cells. So what is important to know is that the CAR T cell, especially for myeloma, is focused on a single target. I think I predict that in the future we'll have additional CAR T cells that will actually affect more than one target, which allows us to have a little bit better control. So the question is, if we go in from one CAR T cell that goes into a specific target, BCMA, and then there is another CAR T cell that is available that goes to another target with GPRC5D, which is another target, do you have a chance to have a better control? So the answer theoretically is yes. The number of patients who went to one to the other is still low. We can extrapolate the utilization of what we call bispecific antibodies, which goes to different, we have different targets that alternating the target actually help us have some improvement on disease control once that happens. So in a sense, if you have two agents, either CAR T cell or antibody, that goes to the same target, the sequence of them, the second one decreases the effect that you had from the prior, treatment. So the idea right now for treatment of myeloma is try to go to a different target. And so the answer to the question is yes, that going to another CAR T cell that goes for a different target may increase the chance for disease control.
Got it. Thank you. This person starts by thanking you for your talk. And they refer to the slide that demonstrated the causes of death for patients post-allogeneic stem cell transplant. Apparently it said that 6% GVHD, and she wants to know, is that usually from acute GVHD? She says, I think of the cause of mortality from chronic GVHD associated with infection and organ failure, but in this particular graph it specifies GVHD as a factor different than infection and organ failure.
Yeah, that's a very good point. Thank you for raising this. So this data comes from the registry, and the cause of death that comes in are related to what the center tells us. So there's no review of exactly where the actual cause is. We try to do as best as we can to understand what was the root cause of it. So in the registry, we ask about the primary cause of death and at least up to 5 contributory causes of death, because things can be complicated, and you can have multiple routes. So as you noted correctly, you could have GVHD that you were treated that caused the risk for infection, and that was ultimately the cause of infection. But sometimes you have to account that the GVHD was the root cause of it. You're right that patients do not, GVHD as a cause of death is usually associated with either organ failure or infection, not necessarily related to the GVHD, but also related to the treatment of the GVHD. So I think it's important to note that we take this as a face value what the center is telling us. And if the center says that the primary was GVHD and the secondary was infection, we take that as that's why it's populated in that graph. So when you have infection and organ failure as a cause of death, those are all could be related to GVHD. The fact is acute or chronic, it depends on the timing. As you all know, you could have severe acute that can lead to these complications, and also chronic. And so we don't separate those specifically in that graph.
Thank you for that. The next person reports, I now have myasthenia gravis. After clinical trial for GPRC5D, CAR T therapy, can I have another CAR T to get rid of the myasthenia?
That's a good question. This is a question about using CAR T cell therapy for treatment of autoimmune disorders. This is an emerging data. There is not a lot experience with that, although there's some studies emerging as the primary indication for a CAR T cell, but this is a CD19 targeted CAR T cell for myasthenia gravis. So there is a clinical trial looking at this specifically, and I cannot tell you if what is the likelihood of benefit for treatment of that of this complication. But I understand that there is this is going to be a niche now of using CAR T cells for autoimmune diseases, and most commonly the indications are multiple sclerosis, myasthenia gravis, lupus erythematosus, and lupus nephritis, and perhaps scleroderma or systemic sclerosis. These are the 5 different indications. There are clinical trials now trying to understand whether using CD19 target CAR T cell will decrease the chance or control for the autoimmune disease.
Thank you for that. The next person wants to ask, what do you think about looking at myeloid genes panel pre-CAR T, and what would you do with the information?
We don't know. This is a very good question. And I try to allude this. I don't want to overcomplicate. So we know that as you get older, you accumulate some of these what we called mutations, and they are small clones that we can detect in the bone marrow. And as you develop them over time, that can increase the risk for development of myelodysplastic syndrome. So these panels will detect those clones. The problem is that clinically we don't know what to do with them aside from monitoring. Whether, because some of these clones that appear in these panels, they may regress over time. It's not a direct linear fashion that people who have it will have increased risk. There is increased risk, but the risk is not a fatal. It is not fate. You cannot, just say yes. It's 100% or 90%. We don't know what to do. There's a lot of studies looking at this right now by trying to look at not only before the CAR T cell, but over time to see whether these clones expand or decrease over time. So it's still a point of scientific exploration to understand whether this. So clinically, doing this or not will not really impact the decision to move to a CAR T cell. This might change in the future, but at the moment, this still remains investigational.
Okay. Does GVHD itself leave you more open to secondary cancers, or is it the steroid treatment that's causing the higher risk?
That's a very good question. So in a normal system, let's say an immune system, as you know, it's a very complex mechanism. So the immune system, we utilize what's called surveillance to see whether a cancer is developing. So throughout our life, we may have injuries in our DNA, and then your immune system takes care of that. And so that's really, for you to develop a malignancy, that cancer has to evade that initial surveillance mechanism that we have in our system. So having said that, after a transplant and with the ongoing GVHD, let's say not the GVHD that gets treated and patients recover and no longer are immune suppressant, but patients still with an ongoing graft versus host disease that's difficult to control, mostly chronic, they tend to have a decreased immune surveillance. So that's why I included in one of those graphs the fact that immune suppression or immune deficiency, either by the graft versus host disease or the treatment of grafts, may increase the risk for it. And then what we see as a lot of association is mostly with skin malignancies, because there is a increased exposure to UV rays that can elicit these much faster, these breaks in the DNA that can lead to a basal cell cancer or a squamous cell cancer. And so it's interesting that some cancers, you have the same issue. Like, for example, chronic lymphocytic leukemia, you tend to have other cancers. So the association of chronic lymphocytic leukemia and prostate cancer is well known, or chronic lymphocytic leukemia and skin cancer is very well known, regardless if the patient receives a CAR T cell or a transplant. It has to do with your ability for your immune system to recognize some of these elements that are appearing.
Very good. This may be our shortest question of the day. How often do you recommend colonoscopies?
It's a good question. I usually follow the recommendations for preventive health, so which is related to age and related to family risk. So it's possible that patients may have a sibling or a parent who had colon cancer at a younger age, which really decreases the age that you start the colonoscopy, or even those new techniques to assess. There's stool tests that look at DNA and all that to have a surveillance. So usually you start after the age, sometimes as early as 40. And then you have every 5 to 10 years, depending on if there was any abnormalities visualized or the magnitude of your family history. So that also plays a role. So it has to be individualized on the patient on when to start.
Makes sense. Next question is, at what point will the secondary cancer risk diminish?
So trying to answer this in a way that, as you being without any treatment, let's say you had never had cancer before, just the fact of being alive increases your risk of having cancer because you're aging. So that's really the baseline of the question. I think that we know the expected risk. Certain cancers may occur earlier than others, as I showed you in one of the slides. So beyond that point, like for example, if you are 2 years after your allogeneic transplant and you're not on immune suppression and you have no active GVHD, your risk for PTLD, for example, that malignancy, is very low. So that will be decreased over time as you regain your immune system risk. However, anybody who received an auto transplant or an allo transplant or any cancer therapy have a higher risk cumulative of a second malignancy compared to the people who never had these treatments before or never had cancer. So the risk will increase with age, but certain kinds will decrease as soon as you regain and recuperate from the transplant.
Mhm. Next person wants to know, do intravenous immunoglobulin infusions increase your risk for a second cancer?
There's no association between those two. Immunoglobulin replacement is a preventive matter for infections. So as patients develop receiving CAR T cells, they will have a suppression on the normal cells that produce antibodies. So they have inability to fight infections, especially upper respiratory infections. They happen very frequently. So more and more we've been recommending that these patients, if they have repetitive infections, or if they have a very low number of antibodies, which is measured by quantitative immunoglobulin G or IgG levels. So the lower the number, the increase the risk of infections. And there's no association that has been described that utilization of IVIG may increase the risk of second cancers.
Okay, here's an interesting one. If your stem cell donor has a family history of cancer, does that increase your risk of a new cancer after transplant?
So there are reports that demonstrate that cancer that developed can be donor-derived. And that has been shown if you have a sex mismatch transplant, like a woman to a man or a man to a woman, that when the cancer originates, the cancer is actually the donor XX or XY chromosomes. Now, that has to be really weighted on the type of the cancer. So if that individual had a colon cancer, the donor had a colon cancer history, it's unlikely that that will transmit into the recipient, because the problem is mostly in the organ, in the colon, not necessarily in the bone marrow. The cancers that we see that have been reported from donor to recipient are usually of bone marrow origin. So, for example, leukemia or a lymphoma that you're able to see if that detects. And there are cases that we've seen with that.
Thank you for that. We're going to have to make this the last question. We're running out of time. And it concerns, can you tell us what is the CIBMTR data, and how far back does it go?
Yeah, so
and what is the role of that data, if you could, please?
Yeah, sure. So the CIBMTR is Center for Blood and Marrow Transplant Research, International Blood and Marrow Transplant Research. So it was established in Milwaukee in the 1970s, and in a sense to understand outcomes. So it was one of the first outcomes databases that were created. And then this became a resource that is funded by the NIH. And so the process is that we have a contract with every center in the United States that does bone marrow transplants, and we collect information on all patients who sign a consent. So if you had a transplant, you would remember that you would someone will tell you about the data registry on the CIBMTR, and that contract is basically or that consent is basically to share information that is de-identified about the outcomes of the transplant. So this is used really, it's a unique resource for the transplant community. We use that to do a numerous study. We use that to inform clinical trials and help design clinical trials. And since 2007, there is a mandatory report of all allogeneic transplant, and the CIBMTR has that contract with HHS. So that data is used to understand the quality of outcome for patients. So This data is utilized to run what's called a center-specific analysis that benchmark the centers based on the patients that are treated. So centers are evaluated based on the expected survival of the patients that they treat. They can be expected a 0, more than expected +1, or less than expected -1. And that became really a report card for centers. It really improves the care of the patients. So the data is utilized for research and also these quality assessments. And how the centers collect their data is also utilized by the FACT to accredit the centers. So the CIBMTR is a resource, and the data is used mostly for research, but also for these other purposes. And since 2017, we've been using the CIBMTR to collect CAR T-cell outcome to understand the outcomes of second malignancies.
Wow, lots of good questions and lots of good answers. That's going to have to do it. So on behalf of BMT Infinite and our partners, thank you, Dr. Pasquini, for a very helpful presentation. Thank you, the audience, for your excellent questions. And please contact BMT Infinite if we can help you in any way. Have a good rest of your day.